Therefore, we have the panelists from that session as well as some fresh panelists joining us today for this discussion. We have Dr. Kalpana Patil, who would be moderating the session. She's a consultant pediatric urologist at Evelina Children's Hospital, London. We also have, as one of the panelists, Dr. Pramod Reddy, who is a division director, Division of Pediatric Urology from Cincinnati Children's Hospital, USA. And we are glad that Dr. Gopal Agarwal could join us. He's a DM neonatology from the very prestigious PGI Chandigarh, and he's a senior consultant neonatologist from Cloud9 Hospitals, Gurgaon, and I'm sure he'll add some fresh perspective to the discussion today. And we also have our very own Dr. Ramesh Babu, who's a senior pediatric urologist from Sri Ramachandra Medical Center, Chennai. So with that introduction, I hand it over to you, Dr. Kalpana, to take forward the discussion. Could you unmute yourself, ma'am, please? Yeah.
Yeah. So thank you for the introduction. And may I add that Mr. Shyam Joshi was my teacher as well. Very early on when I was doing my second SHO job, I was in urology unit, which was headed by Dr. G.H. Tilak, Dr. Madhav Kamath, and Dr. Shyam Joshi. So I know Dr. Shyam Joshi right from the very beginning, not only professionally, but personally as well, because there was another doyen of urology, adult urology, Mr. Fadke, A.G. Fadke, who was my husband's mentor. So through social contacts with him, he was a very social person. And through his contacts, I knew Dr. Shyam Joshi, as we address surgeons in India as doctor, professionally and personally. And the last professional contact was in the USI meeting. I think it was 2018 or 2017 in New Bombay. That's when I met him, met Dr. Shyam Joshi last. So I too have great regard for his teaching. And he was always the heart of any meeting discussions and controversies. And I'm glad that we have the occasion to pay respect to him. So coming to these meetings, I wanted to clarify one aspect, and I'm happy for any of the panelists to contribute to it. Are these webinars going to be continued in pediatric urology, addressing different topics, or how is the function going to be taken forward? I'm not very clear.
Yes, Dr. Kalpana, so I'll answer on behalf of the Society of Pediatric Urology that we have here, that we plan to continue these meetings in the form of webinars addressing different topics one by one. So that is like a continued discussion and webinars that we plan to have, yes.
In which case, equally, hydronephrosis, how are we going to break it up and discuss? Or was that my remit today?
No, we had just planned on discussing the antenatal hydronephrosis part of it. So as you mentioned that some of the questions were left unanswered from the previous meeting. Yeah. So we just take it forward from there. We haven't sort of subdivided, we haven't sort of planned on, the next meeting on hydronephrosis as such. But wherever we leave today, we can always pick it up from there.
Okay, fine. And with regard to prenatal urology, if I, in a very snapshot given idea of what its health is in the UK, it's a, how should I put it? It's quite an important subject, but it doesn't get its due credit. So you get a referral in the National Health Service in UK for a baby who's born in the periphery somewhere and comes to the regional center. The prenatal history is lost. The important jigsaw doesn't connect to the postnatal history, despite having a national healthcare system, simply because the mother is scanned in the local hospital and the scanned reports were in the mother's name. Then the mother goes and delivers in her local hospital. And then the maternal details remain in her case file. The baby's case file is new and separate, and physical transferring of the ultrasound prenatal scan findings doesn't travel into the baby notes. And from then on, that bit, that important jigsaw, loses its pathway. And I've in my setup, I have tried and made a few changes, but obviously in different setups, the background is different. The way the patients are transferred, it's different. The person who scans mothers and then subsequently babies comes from different specialties. So one of the most important thing, what we could address gradually after planning, is how do we give this a relatively simple, pathway. So I fear I might go into the details of what I did in this department, but that's not my intention. What would be good in the medium to long term is to find out, have a denominator, what is being practiced, at least in the continents, and see what, say, for example, we don't have the benefit of something happening in India, then we learn from there and we adapt to that, and vice versa. Because if we miss the important physiological behavior in the prenatal period, we are missing a lot, which affects the management of this child. And although I've been given the role of moderating, I would want everyone to step in and discuss these things. So even before we start discussing how do we handle the parents, what we say to parents in the case of a unilateral hydronephrosis, mild unilateral hydronephrosis, which is obvious and severe, and then go on to the bilateral hydronephrosis. Even before we go into discussion of what we say to parents, I think the other aspect of how we transfer the important physiological changes in the prenatal period for fetal uropathy into the perinatal period is something I would like to discuss. And I would ask Pramod what they follow. I'm sure we've heard him in his recent webinar and talk, but on a more practical note, Pramod, what do you think about these thoughts?
There's no question you bring up an important point, which goes to closing the loop. If you don't have the beginning of the loop, how do you close the loop, right? So I think ensuring that you as the perinatal urologist and the whole team has access to maternal history is really important. Knowing what the antenatal ultrasounds revealed during which portion of the pregnancy were those findings found, what's the status of the amniotic fluid, and maternal history. There are some important aspects of maternal history that might be relevant to the prenatal diagnosis that we're looking at. And whether they had amniocentesis, whether the karyotype done, all these are very important pieces. So what we do in our fetal care center is that we have a pretty rigorous intake process. We are a quaternary fetal care center, so we get patients from a really broad expanse. And so we have a nurse practitioner whose job is to try and get all of that information in. When we see the mother in consultation, her chart is then linked to the baby's chart. Everything's electronic right now. So it was something that we requested to be able to link the mother's chart to eventually, when the baby's born, the baby's chart. So when I click on the baby's chart, there's a tab there that is the mom's chart. So I can see the maternal history. I can view the images of the ultrasounds, even if they were done somewhere else. Right now, within the United States, most radiology departments can do a pretty seamless transfer of the images. This is one thing I would just on a side note say, that as urologists and pediatric surgeons who take care of these babies, it's important for us to really learn to read those ultrasounds ourselves and not rely on the radiologists alone, because we have one very important additional benefit, which is we have the medical context within which that imaging was done, which sometimes our radiologists don't have. And so please get in the habit of reading the images yourself, and then look at the report to confirm what you saw, rather than reading the report first, because that's going to bias your mind. You're going to get an anchor bias. You're going to see the diagnosis, and then you're going to see what you're being led to look at in those images rather than the other way around. So for all the trainees on the call too, I would definitely say, look at the images first, then read the report to say, are you seeing exactly what your radiology colleague is seeing, or are you seeing something different? But we are now able to link the charts. So I think that overcomes a big hurdle, which you brought up, Kalpana.
Kalpana, you are muted. Can you unmute yourself, please?
Can I ask Pramod that in your setup, the software that is used for maternal scans, maternal history, and that for the baby which you use, are they the same? Or it doesn't, maybe it doesn't matter because it is linked, but can I ask, are they the same software system?
So it depends. If the imaging is done in our hospital, then yes. I would say about 40% of the hospitals in the United States are now using an electronic medical record called Epic. So we're on Epic. There are two other big competing medical systems. Unfortunately, if they're on the other system, then we request the records to be transferred to us via email.
Okay. And does it always work in your setup? Does it always work, the transfer from other systems?
So I would say about 95% of the time. And like I said, we have a dedicated nurse whose job is to do that intake.
Yeah.
These families, you know, they fly from other cities into Cincinnati for the consultation for a team meeting. And it would be a big waste of their time if we didn't have all the information ahead of time. So we reach out to them, MFMs who's referring the patient to us, their hospital. We as soon as the contact is made for the referral, we get permission from the family to get access to the medical record. So there is someone who is actively working on that for us. And so I think, you know, it takes work. There's no question. It takes a lot of very proactive work, but it's important. And it is, as you mentioned, you know, if you don't have that information, it makes the subsequent work that you do a little bit more challenging.
Yeah. And Ramesh, what about your setup?
Yeah. See, we have, I mean, I work in a private institute. So we have two kind of patients. One, the ones who come for prenatal counseling. So yeah. I get to see them and register in my name. So I have a way of recording it in the OP file. So the mother's outpatient file will have whatever discussion I've made, whatever findings I have noted on the ultrasound, as well as the reports available. We also in India, we get the printed reports mostly to the parents. Yeah. So they come with the printed report, which makes life slightly easier. But the problem sometimes is the ones who I have not counseled, so new referral. So a baby who was seen elsewhere or not counseled by me, and they get delivered in our center. And then these patients are seen by the neonatal team and they call me. So at that time, they say that this is the baby who we have done an ultrasound on 48 hours and there is no hydronephrosis. There is a history of antenatal hydronephrosis. They just say that. Now I get worried about that because I give more value to the last prenatal scan where the baby was not dehydrated, baby was normally producing urine, everything. And after birth, everything goes through oliguric phase and then it may unmask or, I mean, you may miss some hydronephrosis. So that is what they give me. So I have to probe into them and then go to the parent and then ask the parent, where is your report? Show me the report. But they usually have it printed report in the hand. So I can actually go and investigate. But usually the pediatric PGs, they may not go and read the report. They don't give that much importance to it. They just write one line that this is a case of an UTD A1 or A2 like that. But that is not enough for me. I'm looking for more details, actually the fine print of the UTD itself. But we get a printout. Yeah.
Yeah. And again, does the practice differ individually, state-wise, or how does it work?
Now, you asked about the software. As you rightly said, we have in the radiology department a software called MedSynapse. But the radiology department actually do the scans only from birth onwards. So the fetal sonologists do a different scan and then they have to store it in a different database. So I cannot go back and then look at the electronic records of the mother's record, as you have said, unless they have printed it out. So that becomes a problem as far as linking of the databases are concerned. But in India, we always give a printout, so the parents have a copy with them.
And is this the sort of a situation in most of the places?
Now there are, I mean, this is about a private setup. Now there are government setups as well as institutional, like Apex institutes, like I do not know how it works in JIPMER or AIMS, but they may not give printouts sometimes, particularly CMC Vellore. So that they will have it in the written in the maternal case sheets. So that is when, like what you said, that kind of problems may happen in some Apex institutes where it is partly government, partly private, or one of those quasi-government institutes. But fully private institute, this is not a problem. Fully government institutes also, it's not a problem because there is a handwritten report is there or a printed report is there.
Yeah, so maybe Dr. Gopal can answer.
Yeah, Dr. Gopal can add a few points on this.
Yeah, that's like a government institute, both PGI as well as your corporate practice, Dr. Gopal.
Yes, good evening all. I would be giving aspect of both the centers. So what during my TM, actually this is a government center, Apex center. We used to get calls for antenatal counseling and just with a printed form. So we did not have access to maternal this thing. Also because of PCPNET Act, we cannot access the software. We cannot go and talk to them. But rare cases where we got very severe cases, we used to discuss with the sonologist or the obstetrician. But there we used to get only the printed form, and then we had to counsel, looking at all the parameters as we, and the kidney, different parameters, bladder, ureter, and then we used to counsel. This was just face-to-face counsel with the parents, and occasionally we used to discuss with the sonologist. But here, where the moment I am working is like it's a private center with mother and child. So we level 2 scans are usually done by sonologist, and suppose they find an abnormality, suppose any hydronephrosis, they refer to a fetal medicine specialist, which is there in-house. They go do a detailed scan and then discuss with us. Usually milder form, they usually just don't discuss or don't refer to us immediately. But yes, they do an antenatal counseling involving us. But in severe cases, they involve us, and we also can access the films also. We also get the hard copy on, we can access the softwares. But looking at the PCPNDT, we don't go in detail of all the scans and all that.
What is PCPNT?
That's the restriction on use of ultrasound machines and softwares, which is there in India. It's the government guidelines.
It's particularly in view of not revealing the sex of the baby. That was the idea of the act.
Yeah. So we cannot have access to all the soft copies, all that. But yes, we get involved with the fetal medicine specialist, and then we counsel the parents. So being a closed date unit, we are actually more involved, and we get access to it.
So generally, who does the prenatal scans? Is it a ultrasound person, radiologist, radiographer?
So routine scans till level 2 are done by the sonologist. And
what is level 2?
Like anatomical survey scan, 16 to 18 weeks.
So the anomaly detail scan where you look if there are any. Yes. So that is done by a radiologist.
Radiologist, yes. And if an abnormality is detected, they involve the fetal medicine specialist, and then further scans are done. So we have one intermediate step in between sonologist and us. So that actually increases the sensitivity, I would say, and it's more fine tuning of management.
Okay, because I think it's understandable that different setups have different ways of doing things. The person scanning, the person managing the baby. But these are such important things, isn't it? The ultrasound findings, because you're basing the further management on these findings. So it becomes very crucial that whoever is doing the prenatal scan knows what they're looking for. And I hate to say this, but I don't know how much a radiologist will pick up the things that we are concerned about. So when we
I'll tell you what happens. Up to 20-week scan, the routine sonologists do it. And if they find anything abnormal, they usually get referred to an expert in fetal scanning. That's what usually happens, because at least after the 20 weeks, if anything is abnormal, they immediately get referred to the higher center, and at least they get to screen those people. So they are not overloaded with every patient. So that's how it happens, even in private setup.
Okay.
Yeah.
Okay.
Dr.
think
Kalpana, if I could interrupt, sorry. Dr. Satish Agrawal was wanting to comment something about his center.
Yeah.
So, Satish sir, would you like to unmute and add your comment, please?
Yeah, it's essentially the same as Dr. Ramesh Babu says. I hope I am audible.
Yes,
Yeah, you are.
Right. See, Gangaram being a tertiary care center, we have a fetal medicine department, an ultrasound department, and an OBG department. So the system here is that the OBG person is the primary referring person. The OBG refers to the fetal medicine, and the report comes back to the OBG person. And then OBG, if they think it's an important thing, then they would involve me or one of my colleagues, and then we would counsel the family. The problem comes, so if it happens within the Gangaram, then we have a clear history available to us right from the beginning. But if the patient comes from outside, see, Gangaram is in Delhi, and Delhi has many good centers for fetal medicine. But outside Delhi, there are several people who have started doing ultrasounds, and their reports are at times variable. And the one practice here in Delhi and around Delhi is patients will have multiple scans. If there is an anomaly picked up in one scan, they would go to another center. They would go to another doctor. And when they come to Gangaram, generally there is a lot of variation in the reports. So we tend to get it repeated at our center. And there are specialist fetal medicine people who take care of this. And therefore, then on, we move on. So this is how it goes. So a lot of variability, a lot of variable reports from different centers.
So is it correct that the prenatal scans which require attention do come to you eventually?
Yes, certainly, certainly.
Okay. Okay. Does anyone else want to add anything to this? My passion for prenatal urology was to take it to a different level, in the sense there's so much variability, which I understand. I'm living in the current world practically. However, I wanted to have discussions whether we can have any inverted comma standardized format. For instance, suppose in India, there's a regulatory body, maybe Society for Pediatric Urology. They, can I use the word regulate the practice? Now, this is a humongous thing to ask for or to demand from anyone. But unless you start somewhere, you will not reach to where you want to be. So because the prenatal scans are so important, can they be standardized in the sense, say, for example, Mrs. X has come to a primary care center in India, whatever that means, and somebody is scanning. Would it be possible for that person to have on his wall what he or she needs to look at? That would be the starting thing. So rather than that person just scanning, which is so subjective, and producing an equally subjective report for the baby to be scanned again. There's no objection to scan this mother again, but if we go down to the primary level and try and help everyone who is scanning over there what they need to look at, and that format, if that format is present in the primary care center, similar format in the secondary care center, and of course tertiary, it will always be there. Yeah. Is this something which
you have great ideas? Whether we have the mandate to implement that is a big question.
That's my question.
I mean, we don't actually. But what we can go ahead is to discuss a patient who actually comes with an abnormal scan. How do we counsel the mom? That part we can discuss, because that we have a control over what we talk to them. So we don't know who to scan what. So we'll go to the next part of it.
Yeah, I agree with Ramesh. It will be difficult to implement at the level of India, where uniform facilities are not available. Like what discussion has happened about software. So what I typically learned from our counterpart perinatology is that there are two softwares which are being used in India. One is local Mediscan or something, and one is made in Germany. So those who are actively in perinatology, at least in Bombay, there must be at least 20, 30 people, sonologists, and some of them are gynecologists who are into perinatology. So they use this software and then they give the printed report. But apart from that, there are many others who do antenatal sonography, but they don't have dedicated software to give the report. And then they will give some report, and then uh, the pediatric surgeon or somebody else will be interpreting that and giving their opinion. So that situation is there in Bombay. And if we go into the periphery, many of them may not be getting even antenatal scans also in the periphery in a small villages. So to implement anything 100% will be difficult, but at the same time, I think it's a good suggestion that we should try and get into it and recommend, like what Ramesh Babu has done, formation of the guidelines. So some guidelines can be formed, and some of us should try and push that at some level. And maybe if it is not implemented today, maybe down the road in 10 years, 20 years, it may become 100%.
Yeah, I entirely agree. Unless you start somewhere, we are not going to reach where we want to be. But that's fine. We can move on.
I was just going to say that it's not just in India. I mean, this is a global problem, even here in the United States, because the barriers are from the healthcare delivery standpoint. There are so many disciplines involved in the prenatal management of a expectant mother. And we have the obstetrics colleagues, we have the MFMs, we have the radiologists, we have pediatric surgeons, we have pediatric urologists. So there's a whole cadre of specialists who are trying to be involved in the care of these families. And the consensus meeting that the American Urological Association put on that resulted in the creation of the UTD classification is something that shows when we bring everyone together, maybe we can have some agreement, but it's hard. And then from the patient standpoint, we know that these families are very nervous and anxious, and they're not going to continue on a normal pathway. And if you look at the Pluto trial, it's just a great example how we may design the perfect study, but if the families driven by fear are going to wiggle around and try and game the system, no matter how well you plan it, the devil's in the details. The families are going to choose whatever they want and try and get the result that they want. So it's both sides. The barriers exist on both sides, in our delivery and on the consumer side. So it's a big problem, but I think that unless we try and start to rectify the situation by getting in a room with our radiologists, with our MFMs, with our obstetricians, that's when we're going to start making a difference. And so it's not just within the perinatal surgical services. It has to extend beyond those disciplines.
Can I give one more part of my understanding? I had discussion with one of our colleague, Dr. Gera, Parshottam Gera, who is at Perth, about all this perinatology. So his boss had visited in one of the IAPS conference. Both of them had come. So I said that it is going to be difficult to implement anything at the level of India. So like even the minor abnormalities are getting terminated. So his boss said that even in Perth, we had the same situation when they started, which was probably about 25, 30 years back. But by today, by law, if any medical termination of pregnancy has to happen for antenatal anomaly, they have to have opinion of pediatric surgeon before, and counseling from pediatric surgeon before they are terminated. So that is at the government level, they have done that. I don't know whether it is feasible in any other countries or not, but there all the antenatal anomalies will go through pediatric surgeons and maybe the team of counselor before they get terminated. And
Can I come to this question, Rasik?
Yeah.
So this brings us to the next question. When they come to us with the scan report, the obstetrician is particularly, or the family, the mother or father, they are particularly looking for the need for intervention, need for fetal intervention, I mean, need for termination, then need for early delivery, need for early LSCS or normal delivery. So that kind of specific questions they ask both the parents as well as the obstetricians. So these are the few answers when we have to address during the counseling, prenatal counseling, and this is something which I would like to discuss.
Okay, so if we discuss unilateral prenatal hydronephrosis to start with simple situation, Ramesh, what do you say? A 32-year-old primary gravida has come for her anomaly scan, and you have access to either the report or even the scan pictures. And what do you say to this to these parents?
Now, as you rightly used to comment, this is a challenge because we need to know first what is the natural history of this problem. Then we need to know how much information to give, and this is the most difficult part I find, because some parents are understandable. Even if they are uneducated, they are able to take the information and then may understand it in their local language. Some people, despite being aware of their English as well as being in an IT background, they are not able to take the information. So that becomes a problem. But we still have to inform them what we are seeing. For example, if it is going to be a mild hydronephrosis or UTD A1, that is where I have to reassure them. I have to draw some pictures, and then I have to tell that this is usually going to be all right. Number of imagings, number of interventions are going to be very little, and those are the patients where I have to reassure them. So that's what the usual scenario is. The transient or a mild one, whether it is SFU grade 1 to 2 or UTD A1, that is the usual scenario where my job is to reassure them. Now, some of these people educated, they get worried that whether this has got an impact on their long term. They particularly ask this question: do they have any long term impact? This is a loaded question because I really don't know what they mean. Does it have any long term impact? Does it have a long term impact in survival or marital life, or whether it has got any dialysis implications? They simply ask this question: doesn't have a long term impact.
So basically, what you've said is very important, Ramesh. At least that's the way I view it. There have been very nice articles on the qualitative aspects of parental psyche when they come to know that their unborn baby has an abnormality, inverted comma. It doesn't matter how mild that abnormality is or how severe it is. The fact that the parents come to know that there is something not normal pushes them over the edge. Their background of education makes some difference, but a not huge difference. Their understanding when they are stressed, as we all know, when you're stressed, all your cosmetic or sophisticated layers peel off and your true thinking comes to the forefront. So handling these parents, how you handle them is very important. Like this paper and this study I'm referring to from Australia, it has qualitatively analyzed all these things. And the most important thing, as you said, is to reassure parents. Now, this reassurance, from my thinking, my experience in life, doesn't matter whether both mom and dad are lawyers or for that matter, even doctors.
Absolutely.
I've counseled surgeons with orthopedic surgeons with their
Yeah.
baby, with them being told that your baby's heart has got a hole in that, your baby's kidneys are stretched and dilated, etc. And the same patient or parent with the baby I've seen postnatally, and they say, what on earth was all that about? And this comes because the prenatal scans pick up abnormalities which may be relevant, which may not be relevant, may be transient. So I think the most important thing while talking to parents with any prenatal uropathy is to take them down to a very comfortable level. How you do it, it depends on your setup. And to talk to them in layman's terms. Don't even start by saying your baby's kidney is hydronephrotic. What is hydronephrosis? You have to split it down to say where the kidneys are situated. Right from there, because you have to take the parental thinking to orientation. The parents need to orient themselves. To you and me, kidneys are situated in the loin. Kidneys have got parenchyma and got collecting system. The parents know nothing about this. Or even if they have a background knowledge, at the time they are told that there's a fetal uropathy, all that goes out of the window. So you have to take the parents along with you. And the appropriate way to do that is not to use medical terminology whatsoever. I found that helps. So when you start saying to parents, and always start with a positive one, your baby's one kidney is normal, and a normal kidney is enough to take your child through life. You don't even need a full single functioning kidney. If you have about 25% of a functioning kidney and it remains functional, it'll tide your child through milestones of life. So always start on the positive side. And then the parents have to, you've met these parents for the first time. So the parents have to, come along with you, have to identify themselves, feel comfortable with your way of speaking, conduct. So you need to give time for all those things in the beginning. I won't go on and on because I'll find it very difficult to stop. So I will stop at a small point and I'll invite anyone from the panel to discuss that and the next important point. Would you like to say something, Pramod?
Sure. So I think that I agree with everything that's been said. This is a very unique part of what we do as physicians. We're counseling a family member about a lot of unknowns because we're making educated guesses based on the limited studies that we have about their unborn child. And I think, I always start off my consultation by looking at the mother and saying it's not her fault, because the mothers come in with an incredible amount of guilt that they did something that caused this. And so I want to make sure that during my team meetings, I look directly at the mother and say, whatever is going on with your baby is not a result of anything that you did, or that's something that you could have prevented. I think that's really important. It is incredibly empowering for the family, especially the mother, regardless of the culture that they come from. The family is looking at the mom saying, this is your fault. And she feels that too. So I think hearing from our team that it's not something that she did lifts an incredible weight off their shoulders. The other thing that I think we all are saying in our own way is that, we need to provide, in this day and age, we have to provide family-centered, patient-focused, culturally appropriate care. And what I mean by that is that, this has nothing to do with the IQ of the family. It has everything to do with the emotional quotient, the EQ. How do they handle this news? And as you've all said, some of these very highly trained professionals, even medical colleagues, they fall apart because it's their child, right? They always think it's going to happen to somebody else. Oh, it's my patient, but it's not my child. And so they have a hard time accepting that. And the most important thing we do is counseling, and it's this journey, right? We have to get them on board with us on this journey. And as we walk down this path with them until delivery, and then we can do a more formal assessment on their child at birth, that's part of that journey, that we have to get them to buy into the concept. And what I mean by culturally appropriate is that, depending on the background of the families, depending on their religious beliefs, I know that it's not appropriate for me to even bring up termination of pregnancy with some of these families that I'm sitting across, because it would be offensive to them. So I think we have to understand what is the background of the family that we're counseling, and make sure that we tailor our counseling specifically to their background. And also, in North America and in other parts of the world, there are, we always hear about wrongful termination of life lawsuits, where medical errors resulted in the death of a patient. Well, in North America now, we have wrongful life lawsuits, where prenatal physicians are being sued because we did not provide appropriate counseling to the family. And the family will state that, had I been told XYZ, I might have chosen to terminate my pregnancy, but now I'm left with a baby that has debilitating medical conditions that I have to take care of. And so the counseling team failed us. And so, we do our best to counsel these families with the information that we have. A lot of it's just anatomic studies. We don't have functional assessment of this child's urinary tract. And I'm sure we're going to get into that later on with some of the studies that we're able to do. But also, I do tell them that, depending on their religious beliefs, their support system that they have with their family, and their own internal system of value, if they choose not to do anything, that's okay. If they choose to terminate the pregnancy, that's okay. We're there not to judge them. We are there to guide them during this process. And I think that's another important thing. We should never import our own biases into the counseling session. We have to leave whatever we believe outside that door and go in there and really provide unbiased care to this family.
So even in UK, you're supposed to provide all the information to prospective parents. And in the end, it is parental choice. And in that information that you provide, the things to provide in case of unilateral hydronephrosis is, what are the prenatal implications? So what do you think will happen to this moderate unilateral hydronephrosis as the baby goes through the rest of the prenatal period? For parents also need to know what happens after birth in the perinatal period. So just sticking to the prenatal period, they want to know, the very first question, or the first few questions here in UK they ask is, will my child need a transplant? Will my child need a dialysis? Those kind of questions. Will my child be born very early? So in order that parents understand what to expect even in the prenatal period, in a unilateral hydronephrosis, I think the first important thing is to reassure them, because in unilateral hydronephrosis, things cannot truly go wrong to influence the general development of this baby. So unilateral hydronephrosis, I would recommend we heavily reassure parents that in terms of the normal looking contralateral kidney, provided it remains normal, should not create any problems. Because in UK, any intervention for unilateral hydronephrosis is a litigation case.
Fair enough.
What would you say, Ramesh?
Yeah, totally agree. Totally agree. I mean, for everything we have said. I think we will move on to the next severe bilateral, or any other point you want to.
We can look at prenatal investigations, because ultrasound is so subjective. Yeah. That what other prenatal investigations are required.
Yeah.
So I think apart from various types of ultrasound, all the sophisticated 3D, 4D do not help urological situations. They are good for surface, like your clefts and other things. So other than ultrasound, we practice fetal MRI, because it's like old-time IVP. In select cases, usually in bilateral cases, usually in trying to define the anatomy better, like if you want to see if there are two ureters, if it's a cryptic duplex, whether it's an ectopic ureter, if it's borderline posterior urethral valve diagnosis to get further details about that. So indication for fetal MRI are not for the routine hydronephrosis. They're usually restricted for bilateral hydronephrosis and to get further anatomical details if the ultrasound scan hasn't provided.
When there is only one kidney imaged in the renal fossa, or if there is any suspicion of an ectopic located kidney or one of the, is that an indication for fetal MRI or not really?
I'll let some other panelists answer, but I'll just add to it that in my setup, we had an ongoing research, hefty research project, and they were inviting fetal uropathies for fetal MRIs. And we made use of that to do several MRIs in absent orthotopic kidney and this thing, and found them to be in the pelvis. Right. And also for duplex system, we did quite a few MRIs to see whether we can pick up the upper moiety ureter, if it's ectopic, if the upper moiety is cryptic. And also in certain cases where it was difficult to identify whether it was a multicystic dysplastic kidney or a significant moderate to severe hydronephrosis. And then we have radiology meetings where we feed back to the radiologists. That's how they get better. So I'll let you and the other panelists answer. Anyone?
Dr. Pramod, do you want to say anything about fetal MRIs? It's not being done that commonly in Indian subcontinent at the moment, if I'm right.
Yeah, so I agree with what Dr. Patil is saying, that you know, this it's a wonderful technology, but it's not indicated for every case of a prenatal anomaly. So in our center, we look at three things. We look at, you know, what's the status of the upper tracts? What is the status of the baby's kidneys on the ultrasound? 2, what's the status of the bladder? And 3, what's the status of the amniotic fluid around the baby? And really the reason for the MRI is to say, are we dealing with a prenatal diagnosis that might warrant intervention? If the answer is based on the assessment of the fetal kidneys, the fetal bladder, and the amniotic space, if the answer is no, we're not going to intervene in this baby, then really don't need to get the MRI. And the MRI is not cheap, right? It's pretty expensive. It's gotten a lot safer. We don't have to give anesthesia now to the mother to sedate the baby. Our MRI scanners have gotten very, very fast now, so that we're able to do awake MRIs as long as the mother is not claustrophobic. So there are those limitations, but you know, so looking at the feature defining, so if we have a solitary kidney, but the bladder is not over distended and there's normal amniotic fluid, we're not going to recommend an MRI, because, you know, normal amniotic fluid around the baby is a very simple test to say, is this fetus's entire urinary tract working the way it's supposed to? If they're getting amniotic fluid outside, even if they have hydronephrosis, there's really no indication for any sort of fetal intervention. So in that instance, you know, we're not going to get an MRI because it's not going to change our management.
Absolutely, yeah.
Right. So I think that one thing that we have to bear in mind is that, you know, we order tests. It's very easy for us to order a test. But what I always challenge my trainees is that, you know, order the test only if you're going to act upon the results.
Yeah.
If you're not going to change your care plan based on the results of that test, then don't order it, because someone's paying for that test. Not you, but somebody else is. And so we have to be careful. And this is how we're going to control costs of healthcare, you know. So I think, so if the upper tracts are, like I said, unilateral kidney, even if it's a unilateral with hydronephrosis, but the amniotic fluid around the baby is normal, we're not going to intervene. If looking at the bladder, if the bladder is cycling on a prenatal ultrasound, if we see filling and emptying of the bladder, again, to me, there's really no indication for ordering a fetal MRI. And then the third thing is the amniotic fluid. If we have a fetus with a bladder that might be a little bit overdistended, maybe some hydronephrosis, but the amniotic fluid around the baby is normal, again, we're going to be cautious in ordering an MRI, because again, if you have normal amniotic fluid, and we're going to say, keep following, for us, the window of intervention is around 28 weeks, because by then the canicular phase of the lung development is already completed. We all know that looking at the results of prenatal intervention, unfortunately, as much as we'd like to say that intervention changed the outcome of the kidneys, we know that our interventions don't deliver that promise. The intervention does deliver a fetus with healthier lungs. And so that's really the guideline for when we intervene and when we should stop intervening, is when your impact on the fetal lung development is no longer critically important. And that's about the 28 weeks. So if you have normal amniotic fluid up to 28 weeks, then we're not going to intervene. And so again, no reason for any sort of MRI studying. So I hope that that's clear how we look at that, looking at the status of the kidneys, the status of the bladder, status of the amniotic fluid, putting that together is going to help me decide, do I need an MRI for this child or not?
Pramod, does that mean you do very few fetal MRIs?
Yeah. So for unilateral hydronephrosis, that family's not getting an MRI. They're not getting a team meeting. They're going to get an isolated fetal consult with just a pediatric urologist. If there is bilateral hydronephrosis with a dilated bladder, any form of any concern for amniotic fluid management, then yes, we're going to get the full team meeting. Now, also, keep in mind that we'll sometimes get consultations very early on, so around the 18th week, where the impact on the amniotic fluid may not be realized yet, because that's that transition period, right? So in the first trimester, the source of the amniotic fluid is coming as a transudate from all of the amniotic membranes, from the fetus themselves and the placenta. And around the 16 to 18 weeks, so the fetal urinary production is going to happen somewhere around the 12 to 14 weeks. It slowly starts picking up. And by about the 16 to 18 weeks, you're now looking at most of the amniotic fluid now being generated by the fetal urine. So we call that 16 to 18 weeks is that transition period where the source of the amniotic fluid is switching from around the fetus to within the fetus. And so when we get that early consultation, sometimes we will get a fetal MRI just to say, okay, well, the amniotic fluid is not really helping us that much at this point. So let's look and see what else is going on. But yeah, we're very judicious in MRIs. As I mentioned, it costs the family about $5,000. Not all insurance companies pay for it. So that's a big burden for families to have to bear. And if we're not thinking that, we do a pre-visit planning session for all of our consultations where we'll review the results and try and optimize so it's a one-stop shop. These families are traveling across the country to see us. We have a lot of their records, so we review the records and say, yes, we need a fetal ultrasound, we need an echocardiogram, what other tests we can get done before we meet them so that we can give them, all that information at one time. So we're very judicious. I think early on, as we were still learning about the impact of the MRI and how it was going to change our management, we were probably a little bit more liberal in ordering MRIs, but I think we've learned to be a little bit more mature, not thinking that not everyone needs an MRI. Okay, it's very helpful. It provides beautiful images, but the question is it really needed for everyone? And is it going to change your management? And the answer is no.
Dr. Gopal, do you wish to add anything to that? And also, could you tell us how much does a fetal MRI cost in a corporate setup in India? Like, what are the cost implications also?
So, cost-wise, Dr. Pramod, we know that it's around 15,000 rupees. That comes to around max $200. It's very, very cheap compared to what you get in US and UK. Over the last 3 years, we got almost 42 cases of ANH as far as I remember. These are our center's data. And we had just got one fetal MRI, that too on the request of parents. Like they were completely after us, like they didn't believe our radiologists and our fetal medicine expert. That was a severe, moderate to severe hydronephrosis bilateral and classical features of PV. We counseled the parents repeatedly, but they were after us for getting fetal MRI to prove that the abnormality is there. And then we got the MRI and the abnormality was almost similar. The last 52 cases, if I talk of, almost like depends on how faith you have on the person who does that. If you're a person who is doing ultrasound and the postnatal outcome is almost similar, you have to believe them. And almost I don't think we've missed any cases or we have wrongly diagnosed any cases antenatal also. So there's no point in proving and doing an MRI. Okay, only in isolated cases where you have unexplained anatomy or want to further go on, then MRI might help. But definitely doing an MRI in Indian setup is not very easy. it's not very easy, and expertise is quite less.
I agree with what has been said so far, that we need to do an expensive, sophisticated investigation in the prenatal period if that is going to change management. And for that matter, we use investigations to change management or to plan management. And also the timing of the fetal MRI. If it is being done for checking the amniotic fluid and ruling out outflow obstruction, then as Pramod said, it needs to be done in his setup around 28 weeks. But sometimes you need to do it earlier as well.
Before. I'm saying we're not going to intervene beyond 28 weeks, but we're
sorry.
usually seeing these families somewhere between 18 and 20 weeks. That's usually when our consultations are occurring. But I'm sorry if I misspoke, but we usually will not intervene in a pregnancy beyond 28 weeks because we don't feel that we're going to change the outcome of the fetus, especially from the lung standpoint.
Okay.
32 weeks is like the absolute maximum that we've intervened in. But usually 28 weeks is we're going to say that's the limit. Even if we see something, we're probably not going to intervene unless there are extenuating circumstances where, you know, we're not sure about the gestational age, you know, because there may be some mistakes made with the dating of the pregnancy. But no, we're usually doing our imaging and consultation somewhere around 18 to 22 weeks. That's usually when we're getting a lot of the families referred to us.
So,
sorry if I misspoke.
Sorry to misinterpret that, but should you get a late referral and it is a male fetus confirmed karyotype outflow obstruction, would you not intervene if they come to you between, say, 20, 29 weeks, 30 weeks?
So like I said, you know, our cutoff is around 32 weeks where we might expect some errors with dating. Again, there, you know, you got a case-by-case basis, right? So a late diagnosis of a bladder outlet obstruction where there's no amniotic fluid, are we going to help that child from a pulmonary standpoint? So we will do an MRI and we will get fetal lung volume assessment. So our colleagues in radiology have got a nice algorithm for measuring the fetal lung volumes, and they'll give us a percentile of lung development. That helps us then counsel a family. If we think that the fetal lungs are underdeveloped and there may be some room for us to help this family, then we will intervene with a shunt. We're probably not going to do anything more extensive because the likelihood of a preterm delivery at that point at 30 weeks might be more realistic with an aggressive intervention. So we'll place a shunt in those babies where we feel like their kidneys are not going to produce any urine, so placing a shunt's not going to be enough. We have offered amnio infusions where we place a amnioport, so it's just a Mediport that we put in, implant the tubing directly into the amniotic space, and that way we can just percutaneously access the port and inject saline to replenish the amniotic space fluid around the baby. So again, you know, the later diagnosis, it's on a case-by-case basis. It's driven by how much the parents want us to intervene, and then what is our team. So everything in our program is a team consensus decision. Everybody has to buy into an intervention. If we feel like it's not going to help and we're putting the mother's health at risk, we're going to hold off.
Yeah.
So we always look at the mother's health.
Yeah, that brings to the next question. What are the indications for early delivery? And I'll start off by just giving an idea what happens in our center here is that we don't make individual decisions. These are joint decisions with neonatologists, the fetal medicine. So I would like to ask the other panelists, what are the indications for early delivery? Ramesh, do you want to answer? Is he not there?
Ramesh, you're muted.
Yeah, so sorry, I got muted. Say that again once more.
Indications for early delivery.
Well, it's not individual decision. In fact, sometimes
yes,
the neonatologists put their foot down and say, we are not delivering this baby early. We don't think it's going to help.
Yeah.
So it's neonatologist urologist and nephrologist.
Yeah, I mean, as you say, it's a joint decision, but indication for early delivery in my based on my advice is only when the amniotic fluid volume is becoming really a problem. Like if the lung growth and everything is going to be a problem, like a baby is heading for anhydromnios kind of situation. That is when I really ask them to go for an early delivery. Otherwise, if for a simple oligohydramnios with bladder outlet obstruction, if I'm going to ask them to deliver early, I'm going to bargain that for a different problem of managing the fetal respiratory distress, retinopathy, NEC, multiple other problems. That's a bargain because I may not gain much. In addition, my personal preference for all these patients is to go for a primary valve ablation. And that is very much possible if the baby is at least 3 kilos. So I am myself, putting myself in a difficult situation by asking for an early delivery unless it is really indicated. So based on my advice, delivering somebody to preterm or before 36 weeks is very, very rare. It's like around less than 5%.
Yeah. Similarly, in UK, the neonatologists don't allow us to deliver the babies before about maximum. If you push them, it is 36 weeks. So they don't let you deliver because, as you said, there are the problems of prematurity, etc., which are difficult to deal with.
Sorry, Dr. Gopal being a neonatologist, maybe he can answer that question well.
Yeah, so I would say timing of delivery is purely dependent on the fetal lung status. As Dr. Pramod pointed out, they do a fetal MRI to see the lung volume and maturity and all that. That facilities are not available in India. So we try to pull it as close to 34 weeks as possible because beyond 34 weeks, the complications of prematurity, which we discussed, NEC and RDS and all that, are quite less. But yes, fluid status determines the thing. Suppose a baby is like fetal FI is 1 or 2. Definitely, we discuss with the sonologist or the fetal medicine specialist as long as possible. Try to pull it. We look at other markers, and if baby is doing well, definitely closer to 34 weeks. What we do. Because outcome after 34 weeks is still acceptable.
So, could you elaborate a little more on the markers, Dr. Gopal? Like, would you see beta-2 microglobulin, or what are the amniotic fluid, indicators that you usually look for?
Yeah, so like AFI is what we follow. Definitely, if the pocket is less than 2, and if it's less, volume is less. Suppose we repeat a biophysical profile for the fetus, and it is fetus is still doing well. We try to pull. If anything less than 3 is very, very severe, that will have an impact on the lungs. So 32 to 34 is still acceptable. Anything less than 32, we don't encourage. Suppose the fetal medicine specialist tell us that the renal parenchyma is really bad and AFI is 1, then there's no point in pulling through. We might have a fetal demise, then we take it on with the parents. Definitely, we take parents into the counseling part. We give them all the options, and then we try to pull as far as 34 weeks.
We have a slightly different approach. Most of the indications for early delivery at our center are driven by the maternal health. So we give the decision-making authority to our MFM and the obstetrician. If there are no maternal indications for early delivery, we still feel like the safest place for the fetus is in the womb as long as possible. Now, as Dr. Agarwal is saying, there are certain indications where we might recommend a different. So if the amniotic fluid is 0, if there's anhydramnios, the likelihood of a cord accident and fetal demise is very high. And so there, again, it's more of a pregnancy issue rather than trying to do something for the fetus. When there's no amniotic fluid, the likelihood of compression of the umbilical cord and losing the fetus is very high. And so for those preventing cord accidents, we will sometimes recommend earlier delivery. But most of the times, we're not recommending early delivery. Certainly for unilateral hydronephrosis, never recommend early delivery. For bilateral hydronephrosis with normal amniotic fluid, we never recommend early delivery. It's for those more involved cases where we might recommend. But the natural history is that most of these babies, where they're pretty sick, their mothers are not going to carry them to full term. A lot of our babies will be delivered with spontaneous premature onset of labor. The other thing to keep in mind, I know Dr. Agarwal and Dr. Ramesh Babu were talking about the complications of prematurity. And besides just the immediate prenatal complications of a preterm delivery, we now are learning that there's actually longer term implications, even delivery before 38 weeks. We are now seeing with a long-term study of longitudinal follow-up with these babies, that there are learning disabilities, that there's a higher incidence of ADHD in these babies. There's a lot more issues with speech development, with anxiety, with psychosocial development. So besides just what happens in the NICU with the necrotizing enterocolitis, with the bronchopulmonary dysplasia, once you get them out of the NICU too, there's lifelong implications for having a baby that was born prematurely. So we try to really keep the baby in the womb unless there are extenuating maternal circumstances that our OB doctor or the MFM was going to recommend an earlier delivery.
Yeah, I think the predictors for prognosis in the prenatal period are slightly difficult in my viewpoint, because if we are going to use any tests or any predictors to help us, because the prenatal physiology is so dynamic through various trimesters, that we need a tool which we can repeatedly use. So just doing a test, even beta-2 microglobulins, doing it just once is not sufficient. That's the way we have been trained in UK, and I entirely agree. And therefore we don't, in the prenatal period, we don't have a reliable, independent predictor of postnatal function. So we will never be in a situation where we can use these investigations, if you like, to help us. Because any investigation that you do, if it's invasive, then it has implication on maternal and fetal health and morbidity. And therefore we have to follow a certain path, and therefore the non-invasive tests like ultrasound are the most popular. And then it hasn't been replaced by another test. Even fetal MRI is not something which you can offer to everyone and forget repeating it through pregnancy. Any
before we go on to the interventions, I was just looking at the chat, and one of the questions there while we're talking about the delivery was the mode of delivery. Do we recommend any particular mode of delivery? And I just want to touch on that before we move on to prognosticating the significance of antenatal diagnosis. So again, I think that the mode of delivery depends more on the maternal history.
Yeah.
If the mother has prior history of C-sections, then we might recommend a repeat C-section. Unless the obstetrician feels like she's a good candidate for a VBAC, a vaginal delivery after a C-section. Or if we feel like there's a higher chance of a cord accident, then they may want to do a planned C-section. If there is, if we've done any sort of fetal intervention, specifically if we've done an open fetal intervention where we've done a hysterotomy, those babies can only be carried for another 10 weeks because there is a significant risk of spontaneous uterine rupture. So those babies will have to be delivered by a C-section and 10 weeks from the time of intervention. But other than those specific indications, most of these babies can be safely delivered via vaginal delivery. Every once in a while, we'll have a baby's bladder so large, or a unilateral UPJ where the kidney is just so distended that it's occupying most of the baby's abdomen. There may be some chance for dystocia and failure to progression of the labor. And so there we might say at the time of delivery, either aspirate the renal pelvis or the bladder just to decompress it to allow for passage of the baby through the birth canal. But again, very, very few indications for us to recommend a C-section, and almost always due to maternal indications, not for fetal indications. The one exception to that would be if we have a baby with a cloacal exstrophy. We would recommend a planned C-section because there's a danger of rupturing the membranes, or if we have a baby with a large myelomeningocele, there also we would recommend a planned C-section to avoid rupturing the meningocele.
Before we go about the interventions, I want to bring up this point Dr. Vikesh is also bringing up right now about this termination. I mean, do you have in the US or UK any time before which a legal termination is allowed, like 20 weeks or 22 weeks, or they can be terminated if necessary up to 24? Is there any week restriction? If there is a severe bilateral UPJ with a dysplastic and anhydromnios, it's a bad risk candidate, and you want to suggest a termination, is there a time gap or a window?
In UK, if I remember right, it is 24 weeks.
Right.
In the United States, unfortunately, because every state has its own
Regulation.
rules, most states will allow for a medical indication up to 24 weeks termination. There are 5 centers around the United States where we can do a late trimester termination for medical indications. And, you know, I think for every consultation that we do, we tell the families that they are within their rights to, we don't ever recommend a termination. I think that was one of the questions, is there any indication to recommend a termination? We don't ever recommend a termination. We say, these are your options. And we give the families options to choose from, which are 1, to continue with the pregnancy. And then if there's any interventions that we might recommend, 2, to do nothing and let biology take its course. And then 3, if the families choose so, they can be offered a termination, but we never make the recommendation for a termination of pregnancy.
That's right. I mean, we also, can I complete this point? I mean, we also do the same way. We do not recommend, but we just lay out the facts in front of them and saying that this is going to be a poor risk candidate. And, you know, there is a little scope for them right from newborn period. They may end up in dialysis. So they have to take a call and then ask for the obstetrician. Now in India, up until recently, a 20-week was the cutoff. So by the time you diagnose this bilateral, you know, bladder outlet obstruction and find that they are very poor kidneys, they normally scan and then things completed. They are like 20, we have a short gap, like between 19 and 20 weeks. Now the law has been little amended. Now up to 24 weeks we can go. So now we have slightly bigger gap. Is that right, Dr. Gopal?
Yeah. So now we can extend it to 24 weeks with advice from a fetal medicine specialist, or we have strong evidence for a life-threatening anomaly. We can apply to the court and we can get permission for that. So
yeah.
Any life-threatening anomaly, we can apply till 24.
Okay. I think in UK, as I said, as Ramesh said, that you offer the various available options to parents. And if they choose termination, we help them by offering them information based on medical grounds. For example, if there's a fetus with unilateral multicystic dysplastic kidney and an abnormal kidney on the other side, then we say to parents that through pregnancy, the likelihood is that this may not carry to term. There will be anhydromnios at some stage. So we help them with that, but at no stage we say one of the indications is termination. And then the parents need help not only from the prenatal consultation, but they need to come back and see the psychologist, the geneticists. So the process is not complete in a prenatal session, because the way the practical clinics are held, the other subspecialties are not there in one room. So when it is situations where the parents have to make a decision about termination, they need the space, they need the platform, they need the information, they need a multi-specialty input to be able to make that final decision. So these parents need a lot of help. And certainly the prenatal and the pediatric psychologists help these parents a lot, because there's so much we as clinicians cannot offer these families. The geneticists also then do various investigations, which helps in the parents in making the decision and also for future pregnancy. So it's not a simple prenatal consultation that these decisions are made in. It's a long process. But we need to help parents in their journey towards making the decision.
And I think just as important as the counseling about the termination of pregnancy is the birth plan. You know, if we're going to allow this pregnancy to continue and the families choose that option, then what's the birth plan? Where are they going to deliver? And if they're choosing not to have any interventions, but just comfort care, because that's also something, you know, some religious practices prohibit a termination of the pregnancy. But they can then choose to say, you know, the outcome for our baby is not going to be good. We don't want to have initiation of dialysis on day of life 3. It's not something that we want for our child. And so we don't want any pain and suffering. And so we have our hospice care team come in and just talk to the family. We have a program called Starshine. And it's just to help families, one, understand that we're not going to do any heroic measures to try and save the baby's life after birth. We're going to allow this baby to pass with dignity, and the families can spend the time. We have a special, you know, set of rooms where they're very, very calming, and nobody's going to go in and keep disturbing them for vital signs or other things. And I think that allowing the demise of an individual with respect is also very important and something very sensitive. And I'd like Dr. Agarwal's take on what's happening in India with that, because I think sometimes we're so focused on preserving life that we forget that dying is biological. It's part of the life cycle, and we're all going to do that. And how do we allow this family to experience that with dignity?
Yeah, it's what you call it, I can't call it specialty, but it's a whole program and process, because then come the questions of in-hospital perinatal period, how you support these families, how you help them take their baby outside the hospital, in the community, in their homes, and how you continue providing support. So we have a whole team which works with the family through all these phases. And sometimes these babies, you may predict the baby may not go beyond 8 weeks after birth, but they live up to 6 months. So the families need support for 6 months. So there is a team which is attached, if I may say, to the family, who takes them through all these processes till the end in a very dignified manner.
One other point Dr. Pramod mentioned, by the way, was planning where to deliver. I mean, as he said, we get to counsel 2 kinds of patients. One are our own patients who are booked in our hospital. The second are the people who come from remote only for counseling. Now, these patients, if they have bilateral bladder outlet obstruction or bilateral hydronephrosis, I strongly recommend them to deliver closer to us, if necessary in the same hospital, if not at least in the same city, so that they can immediately come to us, rather than delivering 3-4 hours travel place away. Often the obstetrician has to be convinced about this, because some of the private setup, they may not want to lose that patient, but we still have to convince them that on the best interest, it is better to do a maternal transfer rather than retrieve the baby in a critical condition. This is something which we document actually.
I agree. Even in a setup like ours, we recommend, if we know this is going to turn out to be bladder outflow obstruction, posterior urethral valves, once the baby is born, it's better that the baby is in a tertiary care center where the nephrologists are there, where the urologists are there, where there's level 3 neonatology unit. However, there may be some practical difficulties in parents coming to the tertiary center to deliver. In that case, we tee up with their local center and help them in managing this baby. So if they're comfortable in passing a feeding tube to drain this baby's bladder, which many secondary centers are.
We lost you, Dr. Patel, we lost you.
That, but we liaise with them. Sorry.
Dr. Gopal, any points you want to add here?
Like as Dr. Pramod pointed out, regarding comfort care, legally, law doesn't stand by us. So in India, we don't have such a law like we can there's nothing called do not resuscitate. If a fetus is viable, we have to give full resuscitation, and that's what law says. So that's the point. We cannot give comfort care officially on papers. We cannot give an option of not resuscitating and just giving comfort care. So yes, we do that unofficially with the parents when we know that the fetus is actually very bad, but on papers we cannot do that in India.
Okay, I don't know whether we have Dr. Kalpana back with us. We will go on to the next point, which probably we will discuss next. After delivery, the timing of the postnatal ultrasound, that is something crucial. We generally avoid doing the scan at in the first 48 hours, and then we get to do the scans at 72 hours. And even if that is normal, we still follow them up at 1 month of age just to make sure that that is resolving or not worsening. Is that your practice also, Dr. Pramod or Dr. Gopal? I mean, Pramod can take first.
So I think, again, it depends on what our suspicion of the prenatal diagnosis is.
Right.
So if it's a unilateral system, we're not going to see that baby in the hospital in consultation for the first week. Because I do think that, again, sometimes as physicians, we are so eager to provide care that we steal the baby away from the mother, and there's no maternal fetal bonding or maternal neonatal bonding that happens. And we, again, know that that's a very important part of the initial care. So if it's a unilateral system that's affected and the rest of the fetal scan is normal, we're going to let them deliver at their own community hospital, wherever they want to deliver. We, again, depending on what our suspicion is this reflux, is this a UPG obstruction, we may or may not recommend antibiotic prophylaxis. And then we're going to say, go ahead and bond with your child, be discharged from the birth hospital, and then come and see us as an outpatient between 1 and 2 weeks of life. That way, then we get an ultrasound. And if we have a significant concern, we may get a VCG. But that ultrasound for a unilateral hydronephrosis is going to happen about 1 week later. And the reason why we want to avoid getting ultrasounds too soon, as Dr. Babu was pointing out, is that during the first 48, maybe even up to 72 hours, there may be some normal physiological oliguria that the fetus goes through from dehydration, from inability to learn how to feed. So there's some transition period from birth to when they actually start making more normal volumes of urine. And if they are a little dehydrated and oliguric, then you're going to underestimate the true degree of hydronephrosis if you get an ultrasound too soon. And so beware that ultrasound that's early on. Obviously, you get an ultrasound, it looks terrible at 1 or 2 days of life, then that's pretty significant. But if it's looking normal and is not concordant with what you saw prenatally, maybe you're getting an ultrasound too soon. Now, if it's a bilateral situation, again, bilateral hydronephrosis, but the baby is stable, the amniotic fluid around the baby is normal, lungs are normal, we're going to, again, allow that baby to go home and be assessed as an outpatient if it's a female. If it's a male with bilateral hydronephrosis, we are going to recommend that on the day of discharge from the birth hospital, they come to our hospital and get a VCG to rule out valves. The other additional.
So I agree with Dr. Pramod. So we look at the patient profile. In case of mild to moderate SFU grade 1 or 2, if we think that the patient might not follow up with us, we get an ultrasound as close to discharge as possible, preferably 72 hours. And definitely normal deliveries where mothers are discharged 24 hours in India, we ask them to do it 1 week. Otherwise, as close to discharge as possible, we get an ultrasound. And patient profile, when we believe that they'll follow up with us, we get it at 2 weeks. That's the standard one. Definitely, we get a repeat ultrasound 4 to 6 weeks. We say that the scans are normal only when we get 2 ultrasounds.
So, what is the scan? How many scans you do if in a unilateral hydronephrosis?
In case of inborns, at least 2. First week, first ultrasound, first week, and then 4 to 6 weeks.
4 to 6 weeks. Great. Yeah. That's pretty much what it is. Like Dr. Pramod said, in a case of a bilateral hydronephrosis, everything changes. It depends on whether the bladder is thickened or if there is an oligohydramnios. In that case, it's absolutely okay to do the ultrasound within first 24 hours. And then that will help us to decide. I mean, in a case of a bladder outlet obstruction, it is not going to look normal. So, I mean, it might also help us to decide for an early VCUG. And just to look for posturethral valve. Dr. Pramod, you were telling something. You please continue that.
I think I may have been going on to the more severely affected fetuses, where
Sure.
you know, if we have bilateral hydronephrosis, again, in North America, most of the indications for fetal intervention are for male fetuses. We don't have any. So the interventions on female fetuses are still considered experimental. Okay, so male indications, we do have bladder outlet obstruction. There are a few centers that have done interventions in bilateral renal agenesis, and the outcomes there, unfortunately, are not good at all. And I think the main difference is that, you know, on one hand, when you have bladder outlet obstruction, you have a fetus that at some point made urine, had amniotic fluid, had fluid around the baby to help the lungs develop. But when you're dealing with bilateral renal agenesis, these fetuses have gone from first trimester amniotic fluid production from around the baby, and then zero urine production. And so for the majority of the canicular lung development, they've had no fluid. And so the outcome is very, very different. Even when we've intervened at 20, 24 weeks in that time frame when they've been referred to us, we've not been able to reverse those early lack of development. And so we have stopped intervening in bilateral renal agenesis, either gender. Most of the bilateral renal agenesis babies that we saw were female fetuses. So that's why I wanted to clarify that. Most of the interventions are done in boys, but in this one instance, we did intervene in female fetuses also. But if you've done any sort of intervention on the fetus, those fetuses should be, again, the birth plan should be to bring them to deliver as close to your institution as possible or within your own institution, so that you can get to assess the baby immediately after birth and then start making postnatal management and interventions as soon as possible.
Pramod, can you tell us about the success or how effective this the fetal shunt procedure for vesicoamniotic shunt for posturethral valves? I mean, what are the findings of the Pluto trial, and then is it really worthwhile these days, or what is the current status on it?
That's a great question, right? So unfortunately, Pluto is a beautifully designed study, and we need more prospective randomized clinical trials to determine if our interventions are making a difference. When you look at the levels of evidence, most of our understanding of perinatal urology is based on level 2 case studies or level 3, maybe some cohort studies, but we've never gone any higher than that. The Pluto study was going to give us a randomized clinical trial. The original study design was for 200 pregnant women to be enrolled, randomized into either observation or a vesicoamniotic shunt. And I think they ended up randomizing only 39 expectant mothers. A lot of the mothers who were randomized to observation only would disengage from the clinical trial and go to another hospital and say, I want a shunt. And so that kind of muddied the waters. There is no question that if you have anhydramnios, that placing a vesicoamniotic shunt is going to be beneficial to lung development if you have ongoing production of urine. So those are the challenges, right? So there's a two-part question to a two-part answer to your question. Is a vesicoamniotic shunt beneficial? The answer is it's beneficial if there's still reversible renal injury where the kidneys are still going to be able to make urine. 2, the benefit is not for the kidneys, it's for the lungs. We have not, since Dr. Harrison introduced the concept of placing a vesicoamniotic shunt almost 40 years ago now, in the 1980s, we have not seen a change in our renal outcomes for prenatally detected bladder outlet obstruction. If anything, we are seeing worse prognosis, and it's because we're now seeing many, many more patients. The prevalence of prenatal ultrasounds has gotten more, so more expectant mothers are getting these scans. We're now counseling a lot more of these families, so we're seeing many more of these diagnoses being picked up, and we're probably allowing for some of these babies not to be terminated. And so we're probably seeing families that would not have been seen by us, or pregnancies that are being carried to term because we've counseled them saying, that we may be able to intervene postnatally and change the outcome. And families are proceeding with that. So I think that despite all of the changes, the advances in maternal fetal medicine that we've made, we have not been able to change the fact that 60% of babies with significant posturethral valves are going to progress to, will have some degree of renal injury, and 40% of them will have end-stage renal disease requiring a transplant sometime in their lifetime. That has not changed in the era of the shunt. So the benefits of the shunt have been clearly for pulmonary development.
And if at all somebody wants that shunt, they are well read, well educated, they want to go for this procedure, is there an ideal time to do the shunt? Because from 10 weeks down the line, you're going to deliver them, right?
No. The intervention is only if we do an open.
Right. Okay.
If I do an open, so we have done a total of, so far in my 18 years that I've been at Cincinnati Children's, we've done 8 open procedures where we partially delivered the baby, and I've operated on the fetus and then put the fetus back in. Since we've done a hysterotomy to deliver the baby partially, those interventions, we only take 10 weeks beyond the intervention because of the risk of spontaneous rupture. But if we're doing a percutaneous or if a fetoscopic procedure, and that's kind of, we're now more leaning towards fetoscopic procedures, being urologists, very comfortable with scope, so we can do a fetoscopic procedure. Now I'll tell you that in theory, it makes a lot of sense. Hey, you got a bladder outlet obstruction, maybe there's posturethral valves. We have not been able to reliably visualize the posturethral valves, even though I get a good look in the baby's bladder. The acuteness of the posturethral curve is so that most of our scopes don't negotiate that curve. So if I can't see the valves, I'm not just going to blindly laser anything. So then what I do is, under ultrasound guidance, I place a wire across the urethra and then place a double J stent across the urethra. And the goal is then, and we always back up any sort of intervention with a vesicoamniotic shunt. So through the cystotomy, we place a shunt. But our goal is to try and get that bladder to cycle, right? We just don't want a bladder that's in a state of complete decompression all the time, because that's not healthy for the bladder either. So we're trying to get these bladders to cycle. We know that placing a double J shunt across, placing a double J stent across the urethra is going to disrupt the valves enough that we might convert a high-grade obstruction to a low-grade obstruction that will allow for some bladder cycling. We also all know that most vesicoamniotic shunts don't last the entire pregnancy. They're going to fall out or get dislodged as the baby grows, or the baby's going to pull it out. So at some point, if you've decompressed it enough that you're going to get repopulation of the amniotic fluid around the baby, that's our goal. So if someone comes in that requests placement of a shunt, I think that it all goes to patient selection and counseling, right? So if you counsel the family and say that, yes, we can place a shunt, but to be very clear with you, the benefit of the shunt is going to give your baby lungs that are going to be healthier. We're not going to change the outcome of the kidneys. As long as they understand that, definitely place a shunt, because having a baby who has healthy lungs is going to be a huge benefit than having a baby that has unhealthy lungs.
Okay. Kalpana, welcome back. We were discussing about this antenatal interventions while you are away. Now we have another 20 minutes to wind up. So I want to go ahead about the ultrasound systems. What systems you prefer? I mean, you have any preference? Do you still use SFU, or have you all completely moved to UTD grading? I mean, do you still value the anteroposterior diameter? What ultrasound parameters in the antenatal scans do you value these days more? I would want to discuss that for the next 20 minutes or so.
Okay, so basically, just one comment.
Yeah.
Prenatal intervention will take few days to discuss, and I think it owes that respect.
Yeah,
we should not go away with the notion that prenatal intervention can be done in a few cases, and that's going to help. It's a very complex topic, and I'll stop there. With regard to the ultrasound classification, if you like,
Yeah.
or ultrasound findings, I think what is most important is, from my point of view, not have a subjective classification, as was the previous SFU. If you have an objective classification, it is useful to compare with subsequent scans. It's useful to compare across units. And therefore, in our setup, what we've done is the ultrasound, the radiologist, how they report after birth, kidney dimensions, calyceal dilatation, parenchymal thickness, AP pelvis, anteroposterior pelvic diameter in the cross section of the kidney. That is the most important measurement. And with that, you have to add on the parenchymal thickness, calyceal dilatation, ureteric dilatation, with bladder volumes. No ultrasound of the kidneys is complete without saying what was the bladder volume when you had these dimensions. So all these measurements should be there in the report. And we traditionally use the GOS experience classification, where I think it was 2,800 scans that Jita Dillon had looked into, and she came up with mild, moderate, and severe. And those are based on the measurements. And I think with time, this was done in 1998, 1999, and with time, we've revised those AP pelvic diameters in the transverse section of the kidney in the mild, moderate, and severe group. So previously, even 5 millimeter used to get the whole shebang of investigations, do ultrasounds repeatedly, postnatally, do all the investigations for them. We moved down from there, and we currently have a protocol which has got measurements on it, and we follow that protocol. And to make it simple, 10 millimeter AP pelvic diameter, you would want to do a postnatal scan within the first week, preferably towards the end of the first week of life, and supplement it with a 6-week scan if there are any concerns remaining. And we are going to move on from there to 15 millimeter, but may I remind, it is not just one cutoff measurement of AP pelvis in the transverse diameter. It has to come with AP pelvis of 15 millimeter with no calyceal dilatation, no parenchymal thinning, no ureteric dilatation, with a bladder volume of 20 mil, 30 mil. That is how we follow the mild, moderate, and severe. Moderate is 30 millimeter, anything more than 30 millimeter is severe. And we've come up to 15 millimeter AP pelvis in the postnatal period. Again, unilateral and bilateral, it's slightly different.
Yeah, Dr. Pramod.
We'll just add that in addition to the measurements, it's also very, very critically important to look at the architecture of the renal parenchyma on the ultrasound. So look at the echogenicity of the fetal renal kidney parenchyma, and also if there's any cystic changes within the parenchyma, because you can have a dysplastic kidney that is not going to have any hydronephrosis, but it's not going to, it's a truly dysplastic kidney. And we know that dysplasia is going to have very, very non-compliant tissue. So that tissue is not going to allow for hydronephrosis. Those kidneys are more prone to having perinephric urinomas because they're just going to, rupture and have a fornicule rupture and blow out, because they can't stretch and accommodate the hydronephrosis that a more normal parenchyma might have. So in addition to the measurements, which I totally agree with, I think that we have to learn to look at the ecotexture of the parenchyma and look and see if there's any cortical cysts, because those portend a much worse prognosis.
Gopal?
Yeah, we usually get the pelvic diameter. After that, National Pediatric Nephrologist endorses the SFU classification, and most of our fetal medicine specialists, if they do ultrasound, they always mention the SFU grading along with the diameter. So for parents' point of view, always prognosticate with the diameter. We always look at the SFU parameters, which Dr. Pramod said, like in the calyceal dilatation, the renal parenchyma, whether there is an axial sign. We always look at the A5 also when we look at the severity of hydronephrosis. Always we are worried about, neonatologists are always worried about hydrops. If there is low AFI with hydrops, that is a warning sign for us. But definitely we follow the AP diameter.
Right. I mean, in our center, most of them have already moved to UTD classification. So, like Dr. Kalpana says, we have all the information. And the UTD is very comprehensive. It includes the hereditary, about the cortex, how the calyces are. In addition, it also gives you an idea of where the APT is. So it really gives you how much you have to give importance to that particular case. Now, I want to quickly move on to the next question, which we need to cover. Let us forget about that the bladder outlet obstruction group or the severe ones. Let us talk about the unilateral hydronephrosis. I want to find out from the panelists postnatal role of VCUG and continuous antibiotic prophylaxis. And that may be a diuretic renogram. When will you do these investigations?
Can I jump in?
Yes, please.
MCUG is done in MCUG under antibiotic cover is done in very select cases. And as you have said, we are not going to talk about bilateral hydronephrosis. In unilateral situations, only when there's a dilated ureter do we do a MCUG postnatally with antibiotic cover.
Absolutely. Absolutely. Totally agree. Pramod.
So I think that, as we've learned more and our management evolves, we try to minimize the interventions, and that's absolutely indicated. So for using the UTD classification for the UTD A2 or P2s, we're going to recommend the ultrasounds postnatally. And if we see anything concerning on that ultrasound, if there's any evidence of bladder wall thickening or a bladder that is much larger than what we would expect with upper tract changes, especially parenchymal thinning, we are going to request a VCUG. I think antibiotic prophylaxis is, we're still trying to understand when do we stop. And Dr. Braga from Canada has done a very elegant study where he looked at the protective benefits of the antibiotic prophylaxis. And I think that the protection is, male fetuses, especially if they're uncircumcised. There may be some benefit to doing antibiotic prophylaxis, but otherwise, for the lower grade, so the A or P0, A or P1s, really no indication for using or recommending antibiotic prophylaxis. And then, like Dr. Patel said, that if I start someone on antibiotic prophylaxis, once I get the VCG, if there's no reflux, I'm going to stop the antibiotic prophylaxis. With regards to timing of the LASIK scan, if we see that we have a markedly dilated, SFU 3-4 hydronephrosis, that's not getting better at that 3 months. So we don't usually see the families back at 6 weeks. After that early postnatal ultrasound, we're usually going to see them back at 3 months. And if that 3-month ultrasound is still showing significant hydronephrosis, we might want to get a LASIK scan to rule out a UPG obstruction.
Okay.
Yeah, I think to complete my answer about antibiotic prophylaxis, in UK, we used to give all suspected prenatal hydronephrosis antibiotics till postnatal investigation, either rule out or confirm the diagnosis. But now we don't give it to everyone. We only give it to the moderate and the severe ones, like the 10 to 15 millimeter without calyceal dilatation, with good parenchyma, without ureteric dilatation. We do not give them any antibiotics, but the system here is such that the baby gets referred back to the general practitioner, and then it's in the remit of the general practitioner to make sure that the baby doesn't have any problem. And if they come back with problems, we get the baby referred back to us. So continuous antibiotic prophylaxis, we do use in unilateral hydronephrosis, but only the moderate to severe ones.
Yeah. May I add what we do in our center. So as you rightly said, we are limiting the number of PCUGs. We have done an audit as well on this part. And then we again confirmed whatever we know already, that when there was no ureteric dilatation, the hit rate of a VCUG is so low that there is no point in doing a VCUG on those without any ureteric dilatation. So even in those with the bilateral but no ureteric dilatation, no evidence of bladder outlet obstruction, sometimes they do get a bilateral transient hydronephrosis, 5 millimeter on one side and then 10 millimeter on the other side. They also, we are now not doing a VCUG because we know that, where a good sonologist is, of course, important. They can tell that the bladder is normal. There was no posterior dilatation. There is no oligo. So these patients also, despite being a bilateral, we are not doing a VCUG. And we are not putting them on antibiotic prophylaxis. As you rightly said, my indications for VCUG is either a ureteric dilatation or an episode of urinary tract infection. In that case, yeah, even without a ureteric dilatation, I would go and then do the VCUG and then put them on prophylaxis, because those are the different groups. So then the diuretic scans, Dr. Pramod mentioned. Diuretic scans, my kind of threshold is like above, by the time I decide to do the diuretic scans, they are usually about 20-25 millimeter anteroposterior diameter with the calyceal dilatation, maybe an amount of cortical thinning as well. So we know that they are heading for a severe hydronephrosis, and we always get a scan at 6 weeks. So we know by 6 weeks that they are heading towards a proper PUJ picture. In that case, we will go for a diuretic scan at the 8th week or something, just to know what's going on.
Yeah, I think that's right. A baseline MAC3 scan is indicated in certain cases. So the very mild hydronephrosis, where only the pelvis is mildly dilated, they do not get the definitive primary imaging. Whereas the others, the moderate and the severe ones, will definitely get the isotope scan at 3 months to allow maturity of the kidneys.
All right.
Somebody was asking IVP in the from the audience. I haven't done an IVP myself, but I understand the value of IVP. So I wouldn't be the right person to say whether IVP should be used or not used.
I don't do IVPs either. There are still a lot of people who like IVPs. They want to see the anatomy. They want to see the ureter after the surgery, maybe. So they still do it. But we have stopped using IVPs because we can mentally get a picture from the good sonologist and the nuclear scan, what's going on. So I've also stopped doing IVPs. Dr. Gopal, any points? Because we are coming to the end of this discussion. Another 5-10 minutes are there. Any points you want to add, Dr. Gopal?
I would like to add that the whole crux depends on how good picture you get. So if you believe your sonologist and the fetal medicine specialist and it correlates with postnatal imaging, then we continue the same care later on. Regarding prophylaxis, we give any baby with ureteric dilatation and any moderate to severe HTN till 4 to 6 week scan. And then later we decide whether to go for VCOG or continue with prophylaxis. We solely depend on look at ureteric dilatation.
Yeah. Okay.
So
Right.
I think going to the topic of antibiotic prophylaxis, I think that why are we prophylaxing? We're prophylaxing to reduce the risk of infection, and the risk of infection is either coming from urinary stasis, from an obstruction, or from reflux, right? And as we look at how our understanding of reflux has changed in the past 10 years, we've gone from treating reflux as a radiographic diagnosis. Hey, this kid's got VCUG that shows grade 3 reflux, antibiotic prophylaxis, and we're going to keep monitoring them, to understanding that it's a much more complicated thing than a imaging diagnosis. It's a biological diagnosis. We know that we've all seen patients with grade 5 reflux that have never had a UTI. And we've seen children with grade 1 reflux that keep getting recurrent UTIs. So we know that the severity of the reflux on the VCUG does not really portend any prognostication on how that child's going to do clinically. And so I think that the majority of these incidentally detected hydronephroses are not going to ever have infections. And that's why we've gone away from doing the routine antibiotic prophylaxis, because we're not doing it in patients who have reflux anyway, right? So if I have a child who has grade 1, 2 reflux, and they're 2-3 years old, we're stopping the antibiotic prophylaxis and we're focusing more on that bowel bladder management rather than worrying about a surgical indication for correcting their reflux. So I think that our mindset has really changed. There's been a big, huge paradigm shift in our understanding of the clinical significance of reflux and to the management of reflux. And so we've just extended that same mindset to the immediate postnatal management of a fetus who might have reflux. And that's the rationale behind why we stopped doing. We used to be very big proponents of antibiotic prophylaxis for all babies, and now we're saying very, very judicious use, because we need to be good stewards of antibiotic use. Otherwise, we're going to end up with many, many, many more resistant organisms.
I entirely agree. As trainees in UK, our seniors didn't allow us to treat radiology at all when other parts of the world were very different. So we've grown up in that you treat the patient, not the radiology. So I entirely endorse that view. There was one question about post-pyeloplasty follow-up. Ramesh, do you think we can answer that?
Yes, what was it?
Post-pyeloplasty follow-up imaging, what you do?
I get an ultrasound at 3 months and a renogram after 6 months. That's my routine. I don't do IVPs.
Yeah. That's true. Depending on your system, even here in UK, because the clinics are so busy that I couldn't see a post-pyeloplasty patient within 3 months. So I set myself 6 months ultrasound, 1 year MAG3 and discharge. So basically, you just need ultrasound to confirm no worsening and MAG3 to say there's no hold up of the isotope.
Yeah.
So the one thing I counsel the families is that after a pyeloplasty, the hydronephrosis is not going to resolve right away. It can take up to 2 years for that kidney to remodel and for the hydronephrosis to be less significant. And then at the end of 2 years, you're probably not going to get any more remodeling, and that's going to be the child's new baseline. So we usually get ultrasounds only, and we'll only repeat a nuclear scan if we see worsening of the hydronephrosis. If the hydronephrosis is resolving like we expect it to, we're not going to subject that child to another MAG3 study or LASIK scan.
Yeah, there was an interesting question I just saw. If patient presents with lump at birth, then we will go ahead with pyeloplasty at birth. I think that's a question. If I take it as a question, if a patient presents with a hugely distended abdomen and a huge ballotable kidney, knowing that this child had hydronephrosis, we don't immediately jump into a pyeloplasty at birth. We do the baseline investigations and then do a pyeloplasty. So the age at pyeloplasty is dependent on when you do the primary investigations. But if there's a ballotable lump, the ultrasound will help you identify whether it's a huge hydronephrosis. But we would want a baseline functional imaging to tell us about the differential function. And in these cases, which I call it as giant hydronephrosis, sometimes you'll be surprised that although it's a giant hydronephrosis with a very little parenchyma, like a cap sitting on top, the function in these kidneys can be reasonably good, and it'll all resolve after pyeloplasty. So the timing of pyeloplasty will be indicated a little bit by the lump in the abdomen, if you like, if that was the question.
May I add a point there? I mean, there was more specific question as well after that on indications for neonatal pyeloplasty. So if I may add, in my practice, the neonatal pyeloplasties happen probably once a year or even less. The reason is like very rarely you get such a huge lumps. But when a lump is huge or the size is more than 40 millimeter or 50 millimeter, usually they are palpable. And if that is the case at birth, some of them, I've seen some of them rupturing also at birth. I mean, I've seen 2 patients rupturing, and then I've had around 15 to 20 neonatal pyeloplasty in the last 20 years for different kind of reasons. The main reason for that is like the huge size, severe calyceal dilatation. I know we cannot get a proper reading before 4 weeks, but we sometimes are forced to do the renogram at maybe 2 weeks. and then go for a pyeloplasty at the 3rd week. But at least it is around 3rd, 4th week, not beyond, not immediately after birth. Very, very, very rare to do a newborn pyeloplasty.
Yeah, in those situations, what I do or what we practice here is do a DMSA scan, because that
Yes,
tells you about the
it gives a
function.
good functional status. Yes.
That's what you're wanting to know,
Yeah.
rather than the drainage. So we do a DMSA.
Yeah, just to continue with that, I mean, I wrote that when they present with lump, we do at newborn, means not at birth, you know, after doing whatever investigations.
Yeah.
Yeah.
So we do also the timing. We don't wait if it's a large hydronephrosis. So you do your baseline investigations and operate. In bilateral cases, there's a little bit of controversy or difference in practice. Some people do simultaneous pyeloplasties. Some prefer to do one side, wait for 6 weeks, and then do the other side. Both options are acceptable, because the results of pyeloplasty are so good these days that it's not a huge problem.
Well, I've introduced a 3rd option as well. He wrote a paper in Indian Journal of Urology where we do pyeloplasty on one side and then insert a DJ stent on the other side, so that you can avoid a bilateral pyeloplasty. It often goes across. So in a bilateral UPG obstruction. But anyway, I mean, we've had a wonderful discussion. If you have any last few points to make, Pramod, you can. Otherwise, we will wind up. It was a wonderful discussion, Pramod.
Thank you very much for this opportunity. I think it's been a really nice gathering of friends and colleagues, and having rather informal just discussion.
Yep.
Unbiased recommendations and practice management, right? Because we all practice in different settings, different expectations by our patients, different expectations by our referring physicians. So it's nice to see what's being done around the world, and also nice to see that together we're all really making a difference on these families and the babies. The one thing I just want to add is that, this discussion that we kind of drifted into pyeloplasty and management of a UPG obstruction, the fact that we're not rushing in to operate on these babies is the same rationale why we don't recommend early delivery, right? You're going to wait 3-4 weeks from the time of diagnosis that you suspect there may be a UPG obstruction to taking that baby to the OR. So the same rationale is that if you have a fetus with an obstruction, really do the safest thing for the baby's overall health, and don't be focused so much on the kidney. So waiting 3-4 weeks, you're going to get that baby closer to term and deliver the baby so that you don't have all those other coexisting morbidities of prematurity. That's the rationale why we've never recommend early delivery for purely fetal indications. It's almost always done by maternal indications. But great discussion. Thanks everyone for participating. I know that the time differences allow for, it's nighttime for you guys in India. It's mid-afternoon for Dr. Patel and morning, but I think it's just nice that we're able to get together and have these discussions. So I look forward to more of these. Thank you.
Thank you.
Apologies for my internet. I think someone in the kitchen started the microwave and something happened to the internet, but I managed to come back. Sorry for that. Thank you. I enjoyed it, but I feel we need to have more discussions on this topic, because it is such a vast topic, and the understanding and good practice is important, even if we practice in different setups. I think the basic norm we should exchange and try and follow that, and that will be great for our patients across the globe.
Totally agree. Yeah.
So, Dr. Kalpana, we'll continue these discussions, like we said in the beginning of the meeting as well. Dr. Gopal, any final words, and then we'll call it a day.
Thank you, Dr. Virender and SPU for inviting me. I am really thankful. It's always good to have an interdisciplinary views on a subject. So it's good that I feel good that I'm putting my point of view. And it's always like antenatal counseling and postnatal management, immediate 4 to 6 weeks. That's what we are more concerned with. But definitely we look at the long-term outcome also, because that's what parents want. And it's good to have pediatric urologists and pediatric surgeons involved. Thanks for inviting.
Sure. Thank you all. Thank you, the audience, for participating so actively.
Bye-bye,
Dr. Reddy.
Bye-bye.
Thank you.
Thank you.
Thank you all.
Bye-bye. All of you stay healthy. Be well. Bye.
Thank you, Dr. Reddy. Thank you for joining.
Oh, Merry Christmas. Merry Christmas and Happy New Year.
And Happy New Year.
Merry Christmas. Happy New Year.